Hi, my name is Dr. Shoaib Malik on behalf of Maxillofacial Institute of Implantology. So far we discussed about the, uh, anatomy, and we talked about soft tissue, we talked about medical consideration, radiograph and occlusion and everything. And we're going towards the more surgical protocol now, starting to understand the basic part that hopefully we get a nice picture, but more into the surgical protocol and trying to get to the next step. We have to understand our tools, the numbers, and some of the complications what could happen. So first thing we're going to talk about the implant itself, so the anatomy of implants, and we'll play with some number games about, remember, these things are not absolute, they're varying on each patient, and you should make your own clinical judgment based on the skills we talked about before. But the numbers, what are the distance and whatnot between each implants, which can help us in treatment planning, and also complication. Now, this is a very soft topic on complication, but at least it'll give us an idea of what it's about. And one of the things about, like we talked about before, once you do a good treatment plan, the complications should be within your own. You should be able to handle the complications if you do follow the good treatment plan and pre-op. So, we're going to start about the implant itself. So, there are so many different companies have so many type of implants, and first I'll always talk about there are two basic type of implants. There are implants that are at the bone level, crestal bone level, and there are implants that actually come out of the soft tissue. They both have their advantages and disadvantages, obviously, because if you're doing it bone level and you're not immediately loading it, you have to do two-stage. But this also gives an advantage to be able to do a two-stage versus implants that are actually outside the crest of the bone. So if this white line is the crest of the bone, most of the implants would be at the crestal level. Some, like I said, would also have a tissue component to it. The implants are generally 99% pure titanium, and there's some alloys that added to be 100%, and sometimes it can even be higher than 99%. So if your patients are ever asking, sometimes we get a unique question about allergic reaction, so we have to find out within that alloy how much are what is constituted for that alloy, because they're not 100% titanium. Um, so when we're discussing the anatomy, we talked about either tissue supported, not tissue, but a tissue implant up to the tissue or at the crestal part of it. The other unique thing that differs implants in the companies are some are tapered, some are parallel. Now they both have their advantages and disadvantages, but usually when you have parallel, they offer a nice passive fit. You make your osteotomy, you get your vertical, and then you kind of have a nice fit in throughout your osteotomy site. And so that's one component versus taper, where you can see it up here, it comes down straight and then kind of tapers over. And again, there's advantage and disadvantages for it. When it's tapered, the advantage is, think about it, when you're drilling, your drill sequence is also going to, each drilling is also going to be tapered. So that means the bottom is smaller in diameter than the top. So that means when you make your osteotomy, the apical portion of your drill, will kind of go in and kind of help you guide through it. Because as you proceed on your drill sequences and you're tapered, the apical portion should actually come in into your osteotomy part, and that kind of helps you guide through it. Obviously, that's not available here. It's not a big deal, but it does help. Either way, if you feel comfortable of a certain implant unit, I always recommend using that, because there's always a learning curve when you switch back and forth, and sometimes it's not even worth it. So, my recommendation is understand the patient, and if you're trying to use different implant, make sure it's a good reason for it, or you have a good understanding for those implants. Have you done practice with them, because they do come with a learning curve. The other thing we talked about, when it's tapered, and if the implants are kind of root shaped versus the more cylindrical part of it. The other thing you have to also consider about, now this has not about tapered versus parallel, is these threads. Now some implant would have very aggressive thread. What does that mean? They really stick out. Some are going to be more dull and kind of right next to it. And what does that mean? Well, if you have an aggressive thread, that's the word I like to use for something that's sharp and sticking out, they tend to cut into the bone. So when are you looking to cut into the bone? When the bone is really hard. So you want to engage into that bone and you kind of cut yourself into it like a knife and you stay there. When I find the bone to be very soft, I tend to use more cylindrical, non-aggressive thread because the bone is soft. You're not cutting through it. It's just kind of waving at it. But if you go in through the cylindrical part, what happens is it actually compresses the bone while you're putting the implant in. So when you put the implant in, the bone around it is very soft. It just kind of compresses out, so you can get a nice tight fit. And you can even do it better by under prepping it a little bit. So you under prep and then push it down, not push it down, but tap it down. And while it's coming down with its dull blades, it will actually push the bone on the side, which can give you a nice tight fit. Unlike the aggressive one, where it won't push the bone down, it'll actually cut through it. So, bone quantification like D1, D2, D3. So if you say D1, you might be thinking about aggressive thread versus D4, where you're thinking about more of a dull thread or non-aggressive thread, and maybe even parallel. But beside the thread part, the shape, honestly, for me, if it's soft one, I will go for here. Aggressive, I will go on that side. The other advantage of parallel is because in the maxilla, maybe in the mandible, your alveolar bone has this kind of shape. And, if you have it tapered, for example, you can see it prevents some errors part of it. So if you're a little bit off in the old way parallel, excuse me, I shouldn't say old way, but in the parallel implant, you might have a dehiscence or breakthrough through your plate, but the taper kind of helps you out. And sometimes even for the nerve part, because remember we talked about in our anatomy lecture, the infraalveolar nerve to the mental foramen goes up in the buccal, so it kind of goes like this. So if it's tapered, you can have this implant placed here a little bit, and they'll give you that extra room to be able to do it. Now again, I don't recommend that, but I'm just saying one of the advantage you can see, and especially in the cosmetic zone, or also where the tapered implant, just by the sheer gives you that extra bone to play with, especially when you have a bone loss in these area. They also resemble the natural tooth, so if you're, so it benefits in the way the forces are kind of passed down to the apex. And like I said, in alveolar ridge that are triangular in shape, it has a nice little benefit to it. The other things we have to consider about implants are the collars. Each company talk about the benefit of it, and then you have to think about what kind of cases that particular case would be. They are machine versus textured, and like this one in BioHorizon, they have that laser lock technology to talk about for the soft tissue. So beyond the thread part, beyond the shape, we also have certain unique characteristic for the collar that each implant company talks about, and you should do some research on it and see what best suits for which patient. The next we're going to talk about the numbers. So again, these are not absolute, but keep these in mind. In general, whenever we're talking about some kind of anatomical limitation, we always like to have 2 millimeter distance away from them. So that would be the inferior alveolar nerve, the mental foramen, the cortices on the lingual part. In some cases, for you guys, I would even put in the maxillary sinus, but 2 millimeters is not really. You can even go to 1, and if you are an experienced surgeon, you can even perf through it. Again, that's for advanced part of it. The nasal floor, the incisive foramen, if you don't feel comfortable going in that area. So those are the area landmarks that you don't want to go through. Give yourself at least a 2 millimeter buffer. Occlusion lecture, we talked about some minimum space 7. I would recommend it between implants. We also talked about that, and I'll go into a little bit more detail. Now this we're going to talk about also when we talk about surgical technique. But just to give you an idea, you need about 1.5 to 2 millimeter if you are for the natural tooth, about 2 millimeters on the buccal and lingual, and you got to be extremely important that you keep that 2 millimeter. Again, you have to keep this important. And then remember, that doesn't mean just here. That means throughout the length of the implant. So you got to be careful for that. So that's why when we talked about tapered, they give you that extra margin of error because if it's a triangular ridge, see how it is nicely adapts to it also. So when we talked about the advantage of the tapered. So this is the basic idea we're talking about. So again, it's about 2 millimeters between the implant and the tooth. And it needs to be about 3 millimeters between the implants itself. So if you're doing a nice long treatment plan. All right, so just quickly change the slide for better numbers. So here you can see between tooth and implant, you can go as low as 1.5. Between implants is 3 millimeters. And then, we have different implant sizes, which is diameter. Now, everybody, again, company has their own trademark when it comes to NP. Would be like a narrow platform, so it'll be like a small size. Then you have your regular size, and then they will define something as a wide platform, the bigger, wider one. So you can see some type of wider, the normal, and the narrow platform. So they all have some have maybe more than these three, character qualification or labeling. But in general, those three is what you're going to see, and they all range between narrow between from 3.0 to 3.6 or whatnot. Regular platform would be about 4 to 4.5, and then wide platform can vary from 5 to 6, and some unique implant companies can even go as 9 for immediate placement on the posterior of the maxilla. But you can at least see, when you're doing your treatment plan, how you're doing your calculation. We got to keep that in mind. And if you're using surgical guides or stent, and your width, make sure we have enough space to be able to do that treatment planning. We also talked about the height itself. Remember we talked about 7 millimeters at least minimum. But now, if you have all your 3 millimeter, keep in mind when you're drilling it, you're going to be in the center of it, right? So this is how you have to be kind of careful. It's not like after each 3 millimeter you're going to put the drill right here. No, so when the drilling sequence comes in, you have 3.7, 3.5. We talked about 3 to 3. About 1.5 millimeter, let's say, and knowing the size of the regular platform is 4.3. So 1.5 plus 1 point or 2, that's how you kind of figure out where you're going to make your first drill. And if there are two regular platform, knowing 3 in the middle, between the two drill, it would be 7 millimeter, right? And between the wider platform, because the implant is about 1 millimeter, close to 1 millimeter wider, with the same 3 millimeter space, it'll be 7.5 between the two drills. So you start here, 7.5, you start here, and now you have two wide, so it'll be 8. Okay? So, keep an idea when you're making your drills for multiple implants, it's not where the 3 would be when we talked about it here. It would be in the middle of it, obviously. It sounds obvious, but just understand the concept. So the distance between the two would be, let's say, 7, 7.5. And again, it's easier with if you know the exact distance. In the soft tissue part of it, for the aesthetic part, we recommend about at the crestal level. And here it says 0.5. Our recommendation would be around, you can be at the crest level, associated with the adjacent CEJ. We talked about it. The key is to make sure we have at least minimum 2, but of your biological width. But I would recommend even 3 for the cosmetic area. And then we also talk about the length of the implant. I like to try to be around 10, 10.5, or greater than that in the non-aesthetic area, just to show we have enough stability to be able to handle the molar occlusion, which we know how many force of newtons there are when we talked about occlusion. We also talked about the survival of the implant, but you also have to look at the maintenance part of it. So, what do we, you can even just break down the survival with success, satisfactory, compromise survival, or the failure. And, the key is the mobility is the key. As soon as the mobility happens, that to me is right there a failure. You're not going to have a mobile implant integrated once the soft tissue has taken place and uh, the implant needs to be removed due to infection, due to non-osseointegration or periimplantitis. That needs to be done. But beyond that, above that, you can still have survival, but it could be a little bit more bone loss than what you're looking for. Then obviously the pus, for example, but those we can manage to a point and stop it. But if it start becoming mobile, that's one of the thing, and obviously pain also. Even after you debride it, clean it, no infection, you still have pain. That's another reason for removal. But you also have to make sure that the implant is the reason patient in pain. There's no other issue right next to it. So again, we'll go in a little bit detail. Most of these companies have a very nice, easy to guide implant drill. They're usually color coordinated, easy to handle. In all these cases, first you find the depth, and then you find what depth it would be. Let's say 9, 10, 11, whatever the number would be, and then you just kind of make the hole wider, wider, and wider. So the key would be the pilot drill that comes in, you get the depth, and then just make it wider. And most of these companies have their own color coordination to kind of help you assist it and your assistant. The next part, just a little bit, I know we talked about this in occlusion also, just to kind of show you example of cement retain and a screw retain, and the kind of advantage in cement retain, and the screw retain advantage is you can retrieve it. But obviously the problem is you also need an access hole, which could be a problem in the cosmetic area. So, they all have their kind of advantage and disadvantage, but to kind of show you an idea of how when you enter to retrieve a screw retain versus when you have to retrieve cement where you have to take the whole thing out. Here's an example of the screw retain. You can see your implant. You can use angle abutment sometimes if you're not happy with the screw retains are coming out. If they for some reason originally are coming out buckled, you can go up to 30 degrees of abutment angulation to try to help it come out on the occlusal part, and then you can cover it up. A little bit about provisional solution. If you're looking for a mucosa supported temporary, we talked about, and we use quite often the flipper. There's tooth supported when you can use a vacuum form template, and implant supported also, healing abutment that we use, and you can even use the CAD/CAM machines. Now, the advantage of up here is because these are not that much expensive. Plus, also you can also use them as a stent itself, like we will talk about when we go into surgical protocol. Just example of the flippers. The other key advantage of it is not just for the cosmetic part or even surgical stent part, but also these teeth can shift, and I have seen in some cases where patients weren't willing to wear the flipper and the teeth moved up, and now you lost that space, and they were not able to be provisionalized. Patient had to get braces done to open the space up again, so we make sure. I would just make it as a rule to provisionalize it, even if they're not in the aesthetic zone. We have individual lectures on this, so I'm not going to go over this at all about pre-op, post-op instructions. But again, understanding that this is all part of our follow-up. We don't just put the implant, but there's a follow-up that needs to be done. Maintenance is extremely important. Make sure they annually visit. Take your PAs annually because you don't want that aggressive bone loss, which in this case will be leading to removal of the implant, especially if you have a long bridge. You want to keep an eye on it before it gets this severe bone loss, and help save patient money and make sure they understand the value of this annually follow-up. Excuse me. You also can, at that time, remove the screw, check on the prostheses if needs to be within 2 years. And the cement part, you should be able to see is nice and clean, and it's not causing an inflammation around the bone area, around the edge of the crown. Check the verify the occlusion. Oral hygiene must be taught. Soft tissue health should be examined and checked and probed. So all these things that we do normally, make sure we do it and keep up with it. In follow-up, we also have to worry about peri-implant mucositis or polyimplantitis. And by definition, the mucositis is an infection disease that describes an inflammatory lesion which resides in the mucosa. The peri-implantitis is an infection disease that describes inflammation lesion which also affects the supporting bone. So one is only mucosa, the other one also is starting to affect the bone. And to diagnose this, the mucositis, which is on the soft tissue, the BOP, is recognized. So we recommend that you have your measurements and keep it there and record it, and use that as one of the diagnoses. Obviously, the redness and the swelling can also be visualized. For peri-implantitis, it's often associated with, you have some pus, deep pockets. Deep pockets also because you're getting bone loss, plus because of the mucus, the soft tissue is also involved. And the key is you also start losing the marginal bone. You make sure you do your probing and your bleeding points, have them charted and recorded, and we'll kind of go over how to, if you have these patients that start developing it, how to intervene and prevent that from going on. So once we have diagnosed peri-implant mucositis and peri-implantitis, what can we do to seize that disease and help retention of our implant? Well, there's a mechanical non-surgical therapy that could be effective in the treatment of peri-implant mucositis, but not in peri-implantitis lesions. So that's a little distinguished. Adjacent local or systemic antibiotics improve treatment results for peri-implantitis. Minor beneficial results of laser therapy have been reported. So it depends on what instruments you have available. Example of adjunct treatment with positive effect in case of peri-implant mucositis includes antiviral rinses with antiseptic mouthwash, self-administered irrigation with chlorhexidine and phosphoric acid in the sulci for about 1 minute. So those are the little, ways to kind of help it out. Open debridement, including surface decontamination, may resolve peri-implantitis, promote bone fill, and may also provide basis for re-osseointegration. That's the ideal condition. But if you can even freeze the peri-implantitis, that would mean for me would be a success by itself. It would be a bonus to be able to get some type of re-osseointegration in that case. However, available evidence for the surgical treatment of peri-implantitis is extremely limited, particularly for moderately rough to rough implants. As a result, no technique can be identified. So kind of talked about it, that even if you apply this, clean it up, because of the rough nature of the implant, you get microbial invasion in there and they kind of settle down, and it's kind of tough to clean that up and completely remove it. But if we do it, we get success, and just at least help freeze the getting worse or more bone loss. Adjunct methods for surface decontamination, including chemical agents like I talked about, even air abrasive, lasers, antibiotic, and whatnot. Specific to screw retain follow-up, like I said, you can have your removal of the prostheses. You can check for the seal, remove the pallet, make sure everything is okay. Expose the screw by drilling it out carefully from resin, so you can have the head of the screw exposed so you can get access to it. We recommend using a rubber dam. Obviously, you can once you have it exposed, taken out, you can check for the implant mobility, make sure everything is clean, and have it reinsertion. But one of the complications you can have from the screw retain is you can have fracture of the component that are attaching, right? So the screw could be fractured. In that case, obviously you have to fabricate a new one. But those are the things that can possibly happen. And obviously, if the screw is being fractured, more than likely is due to parapuncture or malocclusion. And one of the lectures we talked about how if it's parafunction, you have your non-axial loading that can dislodge or fracture the screw itself. For cement retain, keep an eye on the follow-up. You don't want the leakage of the cement that can cause inflammation and crustal bone loss. Very, very important, especially in the anterior cosmetic area. Now, there are other complications that can happen during the surgery itself. When you done your flap, your surgery, you there could be a persistent edema, the swelling, but it should decrease between 3 to 4 days. If not, it could lead to wound dehiscence because the edema itself could be, uh, increase in size of the soft tissue, and that can lead to the, let's say, breakthrough of your sutures prematurely and causing a dehiscence. So, keep an eye on that. Hemorrhage itself, be careful when we're talking about the mandibular side of it, where the lingual cortex and the artery we talked about, be careful. So those are the things that can happen. But if you do, these things shouldn't happen. First of all, you should be a couple of millimeters away from it. And second of all, with the tools that we provide, the radiographs and the mapping, remember that where you make the suction and you map, that should help you avoid even coming close to this. Peri-implant infection, we kind of touched on that earlier also. Usually refers to the condition involving the soft tissue, mucositis. We already talked about the implantitis where the bone is involved, and it appears between 5 to 10%. So again, you can have it, but we talked about local debridement, antibiotics, other ways to be able to at least take care of it and freeze it. So the treatment should be, we talked about, improve your oral hygiene, flap in case of peri-implantitis where the bone is involved, so you can debride it, clean it up. Understanding that you will see, so in the literature we report an average amount of 1 millimeter of marginal bone loss during the first year. So you are expected to see about 1 millimeter of bone loss, regardless if you have any kind of pathology or not. And after that, zero 0.1 per year. Only small percentage of successful implant cases exhibit more than 2 millimeters. So after first year, if you have more than 2 millimeter, maybe you need to understand that it might be a possible implant failure, or you need to be aggressive at that time and make a flap and kind of clean it up and hope it freezes at this mark. Various studies also indicates that the complete recovery of osseointegration may be difficult once the peri-implant bone is destroyed, so which is common sense. If you have all the bone around the implant being destroyed, you have mobility, thus the survival rate will be low. One of my key, I have a pet peeve with the occlusion part. You got to make sure in your implants is axial loading on single implants. It dislodges the crown. It causes bone loss at the crustal because that's where most of the forces are going to be, around 4 to 5 millimeter of the crustal bone, and you have a fast bone loss in that area. We talked about mobility and severe bone loss. Those are the cases where there's not much you can do and the implant needs to be removed. So don't be shy. Don't try to be hero and, and think you can miraculously fix something. Meantime, you have a patient that's been dragging along throughout the whole time. If you saw, like we talked about, you have more than 50% bone loss, or you see mobility, or you can see the evidence of aggressive bone loss, and it hasn't integrated, take it out. Put the bone in there and have them come back and do it again. And this part, again, I always tell my patients that there is no tooth there already. You're not making it any worse for them. When you're telling them in your consultation, you always should talk about possible failure, and you should say, even if it doesn't work, we'll get you the implant. Might have to do it one more time after the bone graft. Make them be prepared so you don't feel guilty if it does happen. But be aggressive in that. And I usually, if I have any of these issues where I know the prognosis is poor, I want a good implant, osseointegrated, that I feel comfortable that they're going to be in patient mouth for a long time. And if I see those issues that are developing and more than 50% bone loss or even mobility, I will take the implant out, bone graft, come back and do it again. Simple as that. Sometimes these forces of things happening are out of our control. Nobody to blame, but I want to make sure the bottom line is the patient gets the best treatment possible for these things. The other thing that could happen is could damage the adjacent teeth. Handling this drill complicated depends on how severely the adjacent tooth has been injured. If the burr damage only the cementum, treatment usually is unnecessary because the cementum will regenerate on its own, and that's the advantage of the PDL and the blood supply for the tooth area. If the burr enters the dentin, you want to wait and kind of see approach if there's any pain or pathology develop after that at the apex of the root due to your damage of the burr. However, a root canal is probably required, and again, be aggressive because if that part gets infected, it can actually affect your implant too. So if you feel like you have done something, be proactive and then, think we can get the root canal done. And make sure this is a possibility you always put in your consent also. A burr that enters the canal of an immediate root canal, removal of the root portion of the apical, whatever the damaged portion is, we would recommend to kind of do the little section and remove it out. So just keep in mind that this is also part of the consent. Now, the one last thing I haven't talked about yet, or I haven't shown you the slide, is the nerve damage. Sometimes if you're aggressive flap, just a stretching the nerve can cause hypoesthesia temporarily, which is the numbness of the nerve, and in inability to poorly diagnose and treatment plan, you can even injure the inferior nerve. In those cases, I would recommend sending to your oral maxillofacial surgeon because they deal with it. There are some protocols where you can do some steroid injections to help the swelling part and traumatize of the nerve. And we might put that information, and I will, in my kind of bank of presentations. They won't have commentary like we did here, but it'll be presentations for numerous things related with implants, some advanced, some not, but just various topic. I'm going to start. There's also obviously there's a site for in our website for various articles that I kind of link it in. So you want to continue that information, and some of them will be related to complication and how to handle those complications. And nerve is one of them. And I want to literally just do a whole presentation on that because that's one thing that is hard to reverse. All the other complications we talked about, you can send to your oral surgeon, you can do grafting, this and that, and kind of help you out, or maybe if you feel like you want to go into the advanced training. But the nerve damage is something you can never get it back. So I take it extremely serious, and I think it deserves its own lecture on its own. So this kind of concludes our lecture on dental anatomy, dental implant anatomy, the implant itself. Just have an idea, the shape, size, threads, collars, how that might affect when we talk about the surgical component, but you should have an idea what it is. Just to look at the drill kit, how, your first is always the length, then the opening of the hole with the different drills. Sequences, the three ideas of the narrow, regular, and the white platforms. We talk about basic numbers between the implants, how to kind of treatment plan those, the distance between each other. We talk about complications and follow-ups. All right, this is Dr. Shoaib Malik, and we'll conclude this lecture. Thank you very much.